First thing I want to say is that Marfan's aortopathy does not equal bicuspid valve aortopathy, and perhaps the best way to show this in a very impressive and shocking manner is to compare this natural history study of life expectancy and causes of death in Marfan syndrome, published by Bicuspid from Johns Hopkins in 1972. This was a real natural history study because there was no intervention for the patients. And it showed that there was poor survival of these patients with an average death age of 32 years. And most of those deaths, 80% of them, due to complications of the aorta. Now, when you compare that to the first contemporary clinical history study of patients with bicuspid aortic valve, you will see that the average entry at that study was also 32 years, but that was the entry. And they were followed for 20 years, at which point they showed an excellent survival, not different than the general population, and no dissections at 20 years. I thought that this paper was not going to be accepted because they would not accept that we didn't find any dissections. But this was very impressive for us. Later on, we demonstrated with a beautiful study by Dr. Delphine Detain, who is not with us anymore, and with Guillaume Jondot. We showed the differences in dilatation rates of the mid-ascending aorta of bicuspid versus the root of Marfan's, and we showed that there was a significant number, as you can see, 43% of patients with bicuspid that actually did not progress over time versus only 20% of Marfan's. And therefore, it appears that although Marfan's and bicuspid share common histologic abnormalities of their aortopathy, the clinical expression of the aortopathy of bicuspid and Marfan is not the same. Now, this came to a climax perhaps when we dedicated our time to study the incidence of aortic complications in patients with bicuspid aortic valve, and we showed that overall the incidence was way less than 1% for all comers with bicuspid aortic valve of aortic dissection. However, the development of aortic aneurysm was significant, about 25% in 25 years, developing aortas of over 45 millimeters. That being said, that the incidence of aortic dissection was very low and way below 1%, it was still 8 times higher than the general population, and patients who had aortas who were greater than 45 millimeters had a higher risk of dissection, which was approaching 0.5% or so. Now, it is important to know that this JAMA study has been reproduced by several independent groups showing that the cumulative incidence of aortic dissection, as you can see in this study by Gentac, is for bicuspid valve very close to the general population, and Marfan's is, of course, much higher. Therefore, the new guidelines in 2022, the ACC-AHA guidelines, now recommend for sporadic, meaning everybody, and bicuspid patients with aneurysms, that the class 1 indication for intervention is 5.5 centimeters of absolute measurement and 5 centimeters or 50 millimeters by experienced surgeons in multidisciplinary aortic team. So as you can see, there is an area between 5 and 5.5, that's the area of 50 to 54 millimeters, where there exists uncertainty in bicuspid aortic valve, even though the usual suspects, as you can see up there, published their initial thoughts on how to manage this business a while ago, noting that in patients with 50 to 54 millimeters, you needed to pay attention to family history of dissection, dilatation of more or equal than 3 millimeters per year, uncontrolled hypertension, the root phenotype, and a personal history of coarctation as risk factors to take into account to decide whether or not to operate a patient. And of course, anybody with 55 or more is a class 1 universal indication for surgery. Therefore, 50 to 54 millimeters remains somewhat of unknown territory, and that's why we decided in 2015, between Arturo and I, to study the clinical outcomes of patients with bicuspid aortic valve and ascending aortas more or equal to 50 millimeters who are under surveillance. And of course, you can see that these are the authors, and this paper is under review in JACC Advances, and you see the usual suspects there. And it's very interesting because we started in 2015, but then, you know, some time lagged around, and then there came the pandemia, and we have, it's a multi-center study where there's a center from Argentina, a center from Italy, several centers from Spain, including Valdebron, and then there was the Mayo Clinic, which was initially about 350 patients or so. However, to increase the amount of patients and to make sure that it reflected the real world experience, we included the entire Mayo Health system, which includes many hospitals which are not, some of them are not centers of excellence, they're just normal hospitals. And therefore, we obtained a significant amount of patients who had, as you can see, aorta measurements by echocardiography, which has been one of the criticisms that it was not done by CT and MRI. It was done by echo. And as expected, almost 80% of the patients that were found to have more than 50 millimeters to be included, 78% were the ascending aortic phenotype, and only 22% were the root phenotype. Of course, of these patients, we wanted patients with native aorta, native aortic valve, without a history of aortic dissection or genetic syndromes, and we further excluded patients that did not have the appropriate follow-up, and a couple that were lost to follow-up. And we ended up with 175 patients for the analysis, which we broke into two groups, a group of more than 55 millimeters and the group of interest, which is that 50 to 54 millimeters, which was 721 patients, of which 31% had early surgery in less than 3 months, and 496 continued under surveillance, which was our group of most interest. And of those 400, of those patients with 50 to 54, 225 underwent early surgery, and then 496 remained under surveillance. Of the more than 55 millimeters, 103 had early surgery, as you can see, a tremendous amount, and 51 remained under surveillance. And these patients overall were followed for 7.5 years, up to 12 years, with the endpoints being aortic dissection, aortic surgery, surgical mortality, and all-cause death. It is very important to recognize that there were overall high surgical rates in this study. Of the 496 patients with 50 to 54 under surveillance, 54% underwent surgery under surveillance at 2 years, from 0.8 to 4 years, and the rest, 46%, did not. Of the diameters more than 55, and this is very important, a total of 93% ended up undergoing either early surgery or surgery under surveillance. It is also important to note, which is very interesting, that of the patients 50 to 54 millimeters, the most common causes for early surgery less than 3 months were the aneurysm alone, and the decision made by the physician and the patient, and a combination of the aneurysm, which is a class 2 because it hasn't reached 55, okay, and severe aortic stenosis or severe aortic regurgitation, showing us, and this is kind of the same when you look at the patients that had surgery under surveillance, okay, this is kind of the same, showing us that this is a disease that it's really a valvular aortopathy, where there is a combination of valvulopathy and aortopathy, and in fact, in both groups, the most common reason for surgery is a combination of valvulopathy and aortopathy. Now, what were the independent risk factors associated with shorter time to surgery in this 50 to 54 millimeter under surveillance? Evidently, age. The younger you were, the more likely you were to be sent to surgery. And this, of course, talks about the possibility of bias, selection bias, because this is a retrospective study. But it's good to know that the maximal aortic size was an indicator of surgery. Valvulopathy was the biggest indicator of surgery, okay? And growth, more than 3 millimeters per year, was also a significant indicator of surgery. Now, let's see the independent clinical determinants associated with all-cause death. And we have two groups here, the diameter 50 to 54 under surveillance, and everybody under surveillance. And as you can see, the determinants of death in both groups, aorta surgery and not smoking, are protective of death for both groups. And very important to note that moderate aortic stenosis is a predictor of death for both groups, but aortic size was not a predictor of death for 50 to 54, while it was a predictor of death when you increase the range from 50 to whatever, to over 55. Perhaps the most important finding, or one of the most important findings, is when we looked at the rates of aortic dissection versus surgical mortality, because here's where the question is the most important. In those 50 to 54 under surveillance, and we found 5 confirmed dissections with 4 possible dissections, which is 1.8% of dissections over 3.8 years of surveillance. And of the 266 that were operated under surveillance, there were 5 deaths within 30 days, which is surgical mortality of 1.9. So you can see that the rate of aortic dissection and surgical mortality is the same. While for the patients more than 55 millimeters, aortic dissection was 6% versus 2% of surgical mortality. As you can see here, the aortic dissection in the group of 50 to 54 was 4% per year. I'm sorry, 0.4% per year, which increases as the aortic size increases, and the all-cause death the same. Therefore, we concluded that in patients with aortas 50 to 55 under surveillance, aortic dissection incidence is low, and the overall rates of aortic dissection and surgical mortality are similar, suggesting a clinical equivalence between surgical and surveillance strategies. Conversely, patients with aortas more than 55 should undergo surgery. And let's remember that aortic stenosis, because this is a valvular aortopathy, is associated with all-cause death in these patients. So, do we need a randomized trial of bicuspid aortic valve 50 to 54 elective surgery versus surveillance? I think we do. But the most important reason I'm here today is because my friend Arturo Evangelista has been a role model, a mentor, and a friend. And I also want to honor the great institution of Vall d'Hebron, where I have had the honor of speaking there in the past, and here one more time today, and honor my friend Arturo, who in research has been what I call a beast, mentor of many, international leader, one of the brightest minds in research that I have known, a lighthouse for many of us, and all done in humbleness, which is very, very special. I think that it is critical for anybody that does this business of medicine to have exhibited true, disinterested, and deliberate kindness, to have inspired somebody else to believe and to shine despite adversity, and to have contributed in an honest manner to the understanding of human suffering through research and teaching. And that has been my friend Arturo, who always happens to speak in sequence. When we speak, we always speak in sequence, and I always speak first for some reason. Therefore, ladies and gentlemen, it is my great honor to have been able to sit by him, to work with him, to laugh with him, and believe it or not, even to cry with him. Therefore, Barcelona, which is a land that I love, this is my son, is always for me the land of Gaudí, the land of Serrat, and the land of Evangelista. And Arturo, I want to thank you so very much for your contributions, but very, very especially, I want to thank you for you.